know, there's an interesting question, and we just had a panel, a little discussion about it. Pro-con, should percutaneous aortic valves be reserved just for inoperable patients? So we've assembled the two colleagues that talked about it, Dr. Sundt, surgeon, and Marat, Tuzcu, who's the interventionalist. You're going to represent that side. So Thor, why don't we start with you? What's the concept of inoperability?
Well, this is one of the challenges when given a debate like this, is that really the question of should it be reserved for inoperable patients? What patients are inoperable? There are very few patients that are truly inoperable. The question is the balance of the risks and the benefits. So if the risk of the operation exceeds the risk of the natural history of the disease, then we don't operate. But if you ask me, is that patient inoperable? It's really no. The question is where on the scale of risks, how much is the risk? And that gets into the issue of which technology you apply in which circumstance. What are the relative risks of the two technologies in a specific patient? Okay,
so Marat, what do you say?
No, I think so. I think that the yardstick that we used in the trial was, if this trial was not available, would you operate on this patient? If the answer is no, for all kinds of reasons. Right. I think cutting, not being able to cut, is not the definition of the inoperability, but as Dr. Sundt said, it is the risk of doing something is higher than not doing. So that's the end of it. I think the focus is, in those patients, it is clearly beneficial. How about the patients that are suitable for surgery? What I try to defend is, if these patients are at particularly high risk, be it very high risk with STS scoring, or the surgeon evaluates and looks at the patient and says that the 30-day mortality is likely 10 to 15%. In those patients, it looks like implementing this technology is non-inferior. It's as good as the AVR. There are pros for one technique and to the other technique. We certainly have a lot of challenges to overcome. But at this stage, I think that it is a valid proposal that in well-selected high-risk patients, this is a technique to use.
I would agree. Let me pose two interesting questions to you. One is that the patient, the consumer, obviously, if you gave them the choice, you know, I'm just going to slip a little catheter in here, I'm going to put this in here, you'll be fixed in 5 or 10 minutes, or I'm going to crack open your chest. I mean, the whole concept of how do we educate the consumers as to the appropriate approach if we get beyond this inoperable question?
Well, I think that's the same art of clinical decision making that we apply when we help patients decide between mechanical and tissue valves. It's about educating them about the pros and the cons and helping them to make an informed decision. We can't make the decision for them any more than we can decide that they like vanilla or chocolate ice cream. Okay. They're qualitatively different. As the risks of the two procedures get closer and closer, they become qualitatively different. And so we have procedures that have different short-term risks, different long-term risks, and different patients will make different decisions. But we certainly have a responsibility to help them make an educated and responsible one.
Excuse me, you did a great, this morning I was intrigued by your talk in the plenary session about really, you outlined the complications and the concept of being prepared. It's not an if-when. So it's really, that's part of the education of selecting the patients too, isn't it?
Very much so. And I think that we also have to be honest and put on the table the relationship between the cardiac surgeons and the interventional cardiologists starting from 1980s. It wasn't always a friendly and collaborative relationship. So we are trying to change that, because I think if only interventional cardiologists or only cardiac surgeon are interacting with the patient, that is not going to be the full story. That is why we now have heart teams, that the cardiac surgeon and the cardiologist see the patient together, they think about the patient together, and they interact with the patient, so the patient gets a very fair shake. Absolutely. For example, in my institution, I really don't look at the patient, I should do TAVR. I'm looking at the patient, what is the best for this patient? And my surgical colleague too, and if we can get this team concept really become a permanent entity in the American medicine, I think that it is as big as the TAVR technique itself.
I think you're exactly right. The other thing that Thor, I would throw out to you is the direct aortics, the minimal. We're talking now about TAVI come in. Then it's really it's an advance in the implementation of the valve and patient protection. So where I think probably initially surgeons thought, gee, this is going to be PCI all over again. But it's really, I see the surgeon and the direct coming into increasing prominence with this.
Yeah, I think if you look at them as complementary technologies instead of competitive technologies, a lot of these artificial barriers break down. They're complementary, just like mechanical valves and tissue valves are complementary technologies. It's for a particular patient in a particular situation, one or the other.
Let me go ahead, too.
I think I completely agree, but I want to go one step further to make the point that we also have to start to discuss how are we going to reorganize ourselves. Because in the current state of things, we can do it in Mass General or Cleveland Clinic, but I'm afraid that it won't be easily doable in a wide variety of health institutions. I think that the issue of cost, issue of reimbursement, issue of who does what, and so forth. So we have to, as leaders in the field, have to rethink how we are going to reorganize this whole service line.
This may not be everybody can do this. I mean, or should do it.
Yeah.
So let me, in finishing, let me put your hats on here, your futuristic hats. 10, 15 years from now, what percentage of aortic valves, severe AS, are going to be done through a non-traditional operative way? If you understand what, and it's a tough one because I'm thinking of Europe, and I was intrigued by your comments this morning. I mean, is it going to be?
Well, so if you include a robotic aortic valve replacement with a sutureless valve, 80–90% will be through a non-traditional way, I'm sure.
Interesting.
I think that transcatheter ways, be it transfemoral or a percutaneous apical approach, percutaneous apical approach without a cut, will probably be conservatively 50%.
You're talking about
by 5 to 10 year period.
You're talking about a direct aortic?
I'm not talking about the direct aortic as it stands now, because I think that the many physicians and the patients will prefer procedures without a cut. Why? Because we almost uniformly send patients on day 2 walking home if it is a percutaneous case. So I'm a very pro-surgical cardiologist, but I think that's the key.
Remember, percutaneous is not endovascular.
Yes.
I understand. That's why I was asking that. Well, I appreciate both of you. I'm, making these comments and appreciate what you've done in the field. You've educated us all and helped many patients. So thanks for joining us.
Thanks very much.
Good to see you again.
Thank you very much.
Thank you, Marat. Good to see you. Thanks.
Great to see you. I really enjoyed working with you.